two, one. Please start, sir.
Okay. Uh, Good evening, doctors and everyone. On behalf of Bayer, I, Nitesh Kumar and Abhishek from Calcutta, uh, welcomes you all to this Bayer Eyesight meeting. And we are delighted to have you join us for this focused clinical exchange. Tonight's session brings together leading retinal expert to explore real-world strategies, treatment durability, and evolving approaches to fluid management. At Bayer, we are proud to support platforms that foster peer learning and evidence-based care. Thank you for being part of this dialogue. And let's begin with the introduction of speakers today. Today we have two speakers, Dr. Shubhadeep Sarkar from Calcutta and Dr. Shobhit Verma from Patna ASG. So let's first begin with the introduction of Dr. Shobhit sir. So Shobhit sir is a vitreoretinal and phaco consultant at Disha Eye Hospital, Kolkata, with extensive experience as assistant professor at KPC Medical College and senior resident at RIU Kolkata. He is skilled in complex retinal surgeries, ROP screening, and cataract management. Uh, Sir has presented at national conferences and published in peer-reviewed journals, reflecting his commitment to advance patient care and education. Sir will be speaking on a neovascular MD, critical information for clinicians to enhance patients' outcomes. And now let's begin with the introduction of Dr. Shobhit Verma. So, welcome you, sir. Sir is a consultant vitreoretinal specialist at ASGI Hospital, Patna, with advanced training at LV Prasad Eye Institute and Shankar Netralaya. Sir brings expertise in retinal surgeries, ROP, and uvea care. Sir is having an award-winning researcher and published author in leading journals. Sir is recognized for his contributions to both clinical practice and academic ophthalmology. Today, Shobhit sir will be speaking on aflibercept treat and extend long-lasting benefits and reduce treatment frequency in NAMD. So now I welcome Dr. Subhadeep sir to start his presentation. Welcome, sir. Sir, I think you are muted.
Can you hear me?
Yes, sir.
So my screen is, can you see my screen?
Yes, sir.
Yes, sir.
Your
Yes.
screen is visible.
My screen is visible, na?
Yes.
Okay. Good evening, all, and thank you, Bear, for this opportunity of mutual learning. So today I'll be presenting on what is neovascular AMD, what clinicians should know. So it is global prevalence of AMD is almost 196 million, and it will increase around 288 million in 2040. World's population is currently almost 8.2 billion, and it's a burden, uh, global burden. So the symptoms: blurring of central vision, visual distortions such as straight lines appear bent, central scotoma, general haziness in overall vision. So this is the initial symptoms you can see, and this is the worsening of the vision, central scotoma you can see over here. Oh. So stages of AMD, it is an introduction, or it is an just introductory graphic presentations. You can see occurs when there is buildup of waste material under the retina. With early AMD, there are typically few to no changes in central vision. With intermediate AMD, drusen are larger and may cause changes to central vision. Stage of AMD atrophic, known as geographic atrophy, and most aggressive and the most sight threatening is neovascular wet AMD, which leads to rapid loss of central vision. So diagnosis is multifactorial. You can there is you can go through these visual charts, Amsler grid charts, retinal examination, that is by fundoscopy, fluorescent angiography, OCT and OCT angiography, and indocyanine grain angiography. So management, it is management goals are, you have to reduce the treatment burden while maintaining vision. So timely treatment is very much important. So early diagnosis is quite essential, quick and needs quick access to the healthcare facilities, improve clinical efficiency, and enhance communications between patients and healthcare professionals. If it is left untreated, permanent loss of vision can occur rapidly after the onset of symptoms. So, what factors drive key mechanisms behind the pathogenesis of wet AMD? So, it is a VEGF, as you can see, VEGF-A placental growth factor and VEGF-A, VEGF placental growth factor codimers. So, VEGF-A acts mainly on VEGF-AR2, whereas placental growth factor acts on VEGF-R1, and VEGF-A, VEGF-I2 both acts on VEGFR1 by 2. So here you can see VEGF-A acts via VEGFR1 and VEGFR2. Placental growth factor acts both directly via VEGFR1 and indirectly via VEGFR2 by displacing VEGF-A from VEGFR1. And heterodimers of VEGF-A and placental growth factors can induce and activate VEGFR1 or VEGFR2 and bind to VEGFR1. So excessive activation of VEGFR1 and VEGFR2 can result in increased vascular leakage, edema, and inflammation and pathological neovascularization. Aflibercept is the globally available anti-VEGF agent that targets multiple mediators. Brolucizumab mainly attacks on VEGF-A and VEGF-A, whereas ranibizumab also attacks mainly on VEGF-A. So VEGF-B and placental growth factors are left unattacked or unaddressed. Here, aflibercept acts on all VEGF-A, VEGF-B, and placental growth factors, leading to inhibition of both VEGFR2 and VEGFR1. Currently available and approved anti-VEGF agents, where you can see the half-life of aflibercept is 9.1 to 11 days, whereas in brolucizumab it is 4.3 days, in ranibizumab it is 7.2, and faricimab 7.5. So the duration of action in aflibercept is more than that of the other anti-VEGF agents. So aflibercept as a choice of anti-VEGF in wet AMD, where you can see through RCTs and RWEs. Here is the ALTER study. So it is a multi-centered, randomized, open-label phase 4 study in treatment-naive patients with neovascular AMD. Mean change of BVCA, you can see there is a two-arm. One is given, injection is given every 2 weekly and then treat and extend. In the other arm, injection is given 4 weekly and it is treat and extend method. So it is a 96, at the end of the 96 weeks, there is significant vision gain, that is plus 7.6 letters, whereas in 4 week, it is 6.1 letters. Average number of injections in both the arms is 10.4 at the end of 96 weeks. In 2 week and treat and extend arm, you can see 41.5% of the patients were receiving injection at 16 weeks interval, and in 4 weeks and treat and extend arm, the 46.3% of the patients were receiving 16 weeks interval injection. And there is a VCVA change line at 52 weeks. You can see with 2 weeks treatment regime, there is 9 letters of vision gain, whereas with 4 weeks treatment regime, it was 8.4. At the end of the 96 weeks, it is 7.6 and 6.1. It is quite comparable. So in first mean number of injections at 52 weeks, it is 7.2, whereas at 4 weeks group it is 6.9, and at the end of 96 weeks, both the group received almost 10.4 injections. So in ALTER, up to 96.2% of the patient extended to 16 weeks interval, and it has been maintained through 96 weeks with aflibercept. Now you can see that at the 52 weeks end, at the end of the 52 weeks, the mean BCVA change, ATTRS letters, it gained plus 10.4 letters. At the end of 96 weeks, it gained 10 plus 10.2, and vision gains maintained for approximately 4 years with continued proactive dosing as per protocol. You can see at the end of 212 weeks, mean visual gain is 7.1 letters, 1 letters, which is uh, quite recommend quite good. So range vision gains with aflibercept maintained through 5 years. Now see change in BCVA from baseline to 2 years. The 12-month follow-up, you can see it is almost 67, almost 6, more than almost 6.5 letters gain at 24 weeks. It is 24 months, it is 6-letter gains. Mean number of injections over 2 years is 3.6. By month 24, 24% of the eyes were being treated at an interval of 12 weeks and beyond. So a study from Moorfield demonstrated that vision gains achieved with aflibercept in first year were maintained in the long term to year 4 with continued proactive treatment and extend dosing. So at the baseline, you can see there is 7.8 letters gain at almost 50 or at the end of the first year. At the end of the second year, it is 7.7. At the end of the third year, it is 7.6, and at the end of the fourth year, it is 6.3. And mean number of injections, you can see in the first year, it is 7.4, whereas in second year, it is 12.3, 3 years, 16.5, and 4 years, 19.3. So it is almost up to 25 injections per year. By 24 month, 52.8% of the eyes were being treated at an interval of 12 weeks and beyond. So again, you can see through Jaggi et al. And proactive treatment and extend with aflibercept led to long-term maintenance of vision gains even in the absence of initial loading dose. So here also in the first year, it is average number of injection is 8.1. In over 2 years, it is 13.2. Over 3 years, it is 19.4, and over 4 years, it is 24.9. By fourth year, the median injection interval was 11 weeks. 35% of the patients met exit criteria and terminated therapy after 2.6 years. And you can see uh, after 1 year, there is 11.8%, 11.8 letter gains. At the end of second year, it is 9.8 letters gain. Third year, it is 10.5, and in the fourth year, it is 6.6. So you can see it is you can see the View study, Alta study, Almustasev et al. Study, Moorfield study, and Jaggi et al. Study. In the first year, you can see in View study, it is average number of injection is 7.7, whereas and here is 4.2. In Alta study, it is 7.1 and 3.3. Whereas in treat and extend, you can see over the first year, it is 7.4. In the second year, in Moorfield study, 4.9. In the third year, it is 4.2. In this fourth year, it is 2.8. Again, you can see in Jaggi et al., it is 8.1, 5.5 in the second year, 4.8, and 5 injections in the last year, that is the fourth year. So PCV is quite common and in Asian population, 22.3 to 61.6% patients are diagnosed with PCV, and PCV is quietly commonly underdiagnosed. Other than in Caucasians, it is only 5.7 to 31.9%, and in South America, it is 11 to 22%. So in our Indian scenario, we are all among Asians, and PCV is quite rampant, though it is quite underdiagnosed. Here is the PLANET study, which is prospective, multi-center, double-masked, sham-controlled, randomized phase 3b by 4 clinical study with patients with PCV across 62 centers. Here, what we do, the 3 initial doses of aflibercept, then randomization takes place. After 12-week, aflibercept are given at 8 weeks monotherapy, and in other arm, there is aflibercept with active PDT. At the end of 52 weeks and at the end of 96 weeks, where the study ends, we can see the mean. We can see here. You can see the letters gaining 10.8 at the end of 52 weeks and 10.7 at the end of 52 weeks in PDT also. So there is no difference between only aflibercept monotherapy and aflibercept with PDT. And at the end of 96 weeks, you can see 10.7% 10.7 letters gain in aflibercept monotherapy, whereas it comes down to 9.1 in aflibercept with PDT rescue therapy. So, proportion of patients with complete polyp regression at the end of 52 weeks, only aflibercept monotherapy it is 38.9 and 44.8 with aflibercept along with active rescue PDT therapy. At 96 weeks, it is 33.1%, whereas in aflibercept with active rescue PDT, it is 29.1. So in aflibercept with rescue PDT, it goes down a bit rather than aflibercept monotherapy. So why shouldn't we go for aflibercept monotherapy? It is always better to go for aflibercept monotherapy in these cases, as the study shows. So, proportion of patients with no evidence of active polyps after 52 weeks with aflibercept monotherapy, it is 81.7%, and with aflibercept with rescue PDT, it is 88.9%. Whereas at the end of 96 weeks, there is 82.1% of the patient shows no polyp with aflibercept monotherapy, and 85.6% of the patient doesn't show the polyps with aflibercept PDT therapy. So here are a number of studies you can see. So Saito, Yamamoto, Osaka, most of the studies are done in Japan, and whereas you can see the Planet study, 8 weeks interval, Planet study mean gain of at the end of 24 months, you can see 10.7 letters gain, and it is quite higher than that of other studies being done. So complete polyp regression have been observed across clinical trials and real-world cases series with aflibercept in PCV. You can see in Planet study, it is aflibercept monotherapy 38.9, aflibercept with rescue PDT 44.8. In Vault study, it is 61.9% at the end of 3 months, and at the end of 12 months, it is 66.7%. In aflibercept monotherapy, Japanese case series, you can see easily it is 47.8%, and 60% in first 3 months. In the next 6 months, Aino, Osakawa, Oishi, it is 77, 77.7, 69.2 respectively. And at the end of 12 months, it is 55.4%. So variability in polyp regression rates are likely due to difference in polyp regression assessment criteria across different studies. So now we are coming up to ocular safety with anti-VEGFs. That is, we are mostly concerned about intraocular inflammation and retinal vasculitis with or without occlusion. So in brolucizumab, it is confirmed safety signal of retinal vasculitis and or retinal vascular occlusion, typical in the presence of intraocular inflammation. Signal included in label following post-marketing reports, which suggest post-marketing rate per 10,000 injection, retinal vasculitis is 5.6, and retinal vascular occlusion is 3.0. Whereas in faricimab, which is most newly launched anti-VEGF molecule, post-marketing rate per 10,000 injections, retinal vasculitis is quite low. It is 0.11%, whereas in retinal vasculitis without occlusion is 0.06%. But you now come to aflibercept 2 milligram, post-marketing rate per 10,000 injections as of November 23, retinal vasculitis is 0.006% and occlusive retinal vasculitis is 0.002%. Now, aflibercept 2 milligram efficacy safety profile has been established across RCTs and is supported by over a decade of real-world PV monitoring. Rate of endophthalmitis after 10,000 units of injection is 0.6%. Rate of intraocular inflammation is 1 in 10,000 10,000 injections sold. So it is, thank you. So what I want to say, and what I went through when I went through these studies in through all these studies, that is, if we give loading doses and then we go for treat and extend method or extend regime, number of injections over the time, it comes less. So the burden of both economic burden and coming and getting number of injections is quite low, and overall vision gain is quite good in case of if you give loading doses. Thank you. Thank you for the patience hearing.
Thank you, sir. Thank you for a wonderful session. Thank you how elaborately discussed the every slide of the PPT. It is very really helpful for our audience for their day-to-day practice. And one thing I want to say the audience, as there are some medical agency, still he is managing his time for our this meeting. So once again, thank you, sir, for your valuable time.
Thank you.
So now I hand over our session to our next speaker, Dr. Shobit Verma, sir, from his. So now the session is over to you, sir.
Are you able to see my slide?
Yes, sir, it is visible, sir. And your voice is clear, sir.
Oh, thank you. So I'll be speaking on aflibercept treat and extend, the long-lasting benefits and reduced treatment frequency in neovascular AMD. So the need for reduced treatment burden with current anti-VEGF agents for patient is increasing. So in 2022 EURETINA Clinical Trend Survey, 72% of the respondents agreed that the quantity of injections is the largest unmet need with current anti-VEGF treatments. So, and regarding the socioeconomic status of our country, this becomes a more major issue. So the treatment approaches in neovascular AMD is either fixed dosing regimen, where we give continuous monthly injections or bi-monthly injections for minimum of 1 year. The other is reactive pro-ray nata regimen, where we give monthly visits and monitoring, and treatment is given as the activity surfaces. The third is the proactive treat and extended dosing regimen, where initially we give monthly 3 doses of injections till the disease is inactive. And once the disease becomes inactive, we gradually increase the gap by 2 to 4 weeks to the maximum to 12 to 16 weeks. So implementing the T&E regimen, so we treat until the disease becomes stable, then we extend the interval, and then extend it until fluid recurs or the visual acuity declines. And we decrease the interval to the previous stable interval, and maintaining the patient at this interval will minimize the treatment burden and fluid fluctuation. So how do we manage the interval? So we extend when there is no fluid is present. We maintain when there is residual but decrease is in the fluid level. And we shorten the interval when the new fluid is present. The Altair study included an option for patients to be maintained on their current injection interval in the presence of residual but decreased fluid. So intraretinal fluid parameters. When we compare both subretinal fluid and intraretinal fluid, what is most important is intraretinal fluid level. Now, the intraretinal fluid are of two types: exudative intraretinal fluid and degenerative intraretinal fluid. So this is decided on the basis of the morphology of the intraretinal cyst and the RPE structure. When the exudative IRF is there, then the treatment needs to be modulated. That means you have to adjust the timing for the injections. Now, the degenerative IRF are identified as a sharply demarcated hyporeflective spaces in the inner retina, overlying areas of RPE atrophy and scarring. Now, these can be considered for treatment discontinuation when the other signs of the disease are not there. Now, it's one example I'm showing. In this, we can see there is subretinal fluid. Now, there are two spots which you can see. There is subtle small spaces where and just overlying that RP elevation, which is suggestive of exudative IRF, which needs active treatment. The other part is when we go more towards the disc, we can see there are some degenerative IRF spaces. Well, these are not supposed to respond to the treatment. So this, if the exudative and the SRF is not there, these can be best left alone. Now, while discussing some cases, this is a case of 73-year-old female who presented with right eye visual acuity of 6/60. Here we can see there's a large hemorrhagic irregular PED with you can see that the subretinal space, there are hyperreflective signals, which is suggestive of subretinal hemorrhage. And there's presence of subretinal fluid as well. This thus indicating that it's an active neovascular AMD. Now, this patient was given 3 monthly doses of aflibercept. Now, the visual acuity improved to 6/18. You can see that the PED, the irregular, the elevated PEDs have resolved significantly. All the subretinal fluid has resolved. However, there was RP atrophy is there and there is scarring. Now, after 3 doses of injection, when the treatment was stopped, then at the 10th week, she again had a relapse. Now, this time this relapse was the swelling was pretty much very high. So the visual acuity reduced to 2/60. Now, again, we gave aflibercept injection, but this time I increased the doses at 8 weeks because that relapse happened at 10 weeks. So we gave 3 doses at 8 weeks interval. For every 8 weeks, I repeated for 3 doses. Now, after that, we can see that that intraretinal fluids as well as SRF has significantly resolved, and that visual acuity improved to 6/60. Now, the same lady in the other eye was having again a neovascular AMD. The visual acuity was better. There was a notched irregular PED, which we can see with SRF. Now, I treated this as a non-aggressive basis because the other eye presented with a very severe form of an AMD. So in this patient, I initially started with 3 doses of aflibercept. The visual acuity improved to 6/12. We can see that the SRF was significantly improved and there was no active fluid. However, at 12 weeks interval, there was a recurrence of the fluid. And the visual acuity dropped to 6/18. So now because that happened after 12 weeks, so I chose the interval for 10 weeks and I gave repeated 3 doses at 10 weeks and she's maintaining good vision in that at 6/12. Now, this is another case, third case, where a 51-year-old lady came with a visual acuity of 6/24 in the left eye. She came with a history of 7 anti-VEGF injections elsewhere. And she was telling that this fluid, every time she is going, and there were 3 loading doses were given of not aflibercept, some ranibizumab biosimilar. And then after that, she was being treated on a PRN treatment basis. But it was of no help, and the visual acuity was 6/24. Now we can see the SRF is there. There was fibrovascular PED is there. There was some foveal thinning, so visual acuity I was not expecting to be much better. So I convinced her to go for aflibercept, and I chose that let's start the treatment, 2 doses. We gave 2 doses, and then I stopped the doses, and I asked her to let's see when the fluid recurs. So after 10 weeks, she came with increase in SRF level. So then I told her that let's repeat this dosing at every 8 weeks, and post 3 doses at every 8 weeks interval. We can see that the significant SRF has reduced. Irregular PED is there. And this is post 6 8-weekly doses. We can see that all SRF has been reduced and the visual acuity is being maintained at 6/18. Now, another case of neovascular AMD where the 68-year-old male presented with a large irregular PED with subretinal fluid. Now, he had a sudden drop in vision. So considering the size of the PED, I was skeptical whether this is a long-standing PED or not. But the patient was very specific that the visual drop is very recent. So I started him on a treatment of aflibercept. So after 3 doses at 4 weeks, 1 monthly injection, that all the SRF had resolved. There was some reduce in the PED height also. Then the visual acuity was being maintained at 6/18. However, as I stopped the 3 doses of injection, so at 8 weeks, the recurrence happened. Again, the patient presented with the drop in vision. So I gave 3 doses injection at every 8 weeks interval. But now at this point also, he is developing again drop in vision, and there was some subretinal fluid. So now the interval has been reduced to 6 weeks. Now the patient's still in the treatment process, so I don't have the further images. So one more, it's an interesting case which I want to show. It's a 52-year-old male who presented with a visual acuity of 6/60. He had a viral retinitis sequelae history in this left eye, and there was a temporal macular break. Now this break was already lasered, temporal edges were lasered already. Now on follow-up, he developed a secondary CNV formation. So it was very difficult to diagnose initially because you can see that the temporal to the fovea part, there is a macular break, but he developed intraretinal fluid, and you can see some irregular RPE layer just at the subfoveal area. So initially, because he was not having a very good visual acuity, so I convinced him to go for an anti-VEGF first. So he was started on ranibizumab biosimilar. But you can see that after 2 doses of the ranibizumab biosimilar, there was not much response. The visual acuity dropped to 1/60. There was subretinal heme, which you can see in this part. And there was scarred CNV with large that intraretinal fluid, and the CRT layer was also very increased in this. So then I convinced him to go for aflibercept injection. So this post 3 monthly doses of aflibercept, and after that the visual acuity has improved to 5/60. Since now it's stabilized, I have increased the intervals to 2 doses at 8 weeks interval have been given. So he's been maintaining quite a good vision. The temporal thing which you can see, that's the macular break, the temporal to the fovea, which he's stable. So one case of branch retinal vein occlusion with recurrent CME I just want to share. It's a 36-year-old male who presented with visual acuity of 6/60 in the left eye. Now, post 4 days of ranibizumab biosimilar, although it responded well, but every 1 month the disease was relapsing after a few weeks. So I gave 2 6-weekly doses of aflibercept. You can see that the intraretinal fluid, their cystoid spaces have resolved quite a bit, and the foveal contour was well established. So then again the CME happened after 10 weeks interval. So again, now I have increased that frequency for the 10 weeks interval and repeated aflibercept injection every 10 weeks. So he's now maintaining a good foveal anatomy, and there's no recurrence. But now I'm planning to increase it to 12 weeks. So what is the main thing about treat and extend is that a patient thinks that every visit is a treatment visit, which is very not for the per se for the expense of the treatment, but the patient in Indian scenario, generally when the patient comes, they just don't want to come and pay for the OCT for every regular frequent visit. And if you say that there's little bit fluid is there, but we have to observe, then they feel that the treatment is not responding, like I'm paying for OCT every time. So once they can consider that every 2 or 3 months when I visit, and if the disease is stable and if it has been maintained for long, then they are pretty much convinced with the treatment and they can continue the treatment. So TNE regimen offers advantages of extending treatment intervals, the reducing the number of clinic visits, and it's comparable or favorable visual outcomes compared with other treatment regimens. Thank you.
Thank you, sir. Thank you for sharing your day-to-day experience and sharing your case study. It really gives the confidence to our audience, because many times we are sharing the data which is mainly published in a study, but when you're sharing your day-to-day experience, it's really add a feather with the study. So thank you, sir. So now the forum is open for the audience. If you have any kind of questions or any suggestion from your side, you can ask to the Dr. Shobhit sir. I think, sir, there is no question from the audience side. Sir, just one thing is just question from my side, that in Kolkata, many doctors prefer extend up to 16 weeks. So that the study we have, but in your case study, you shown that you are extend with one patient with 8 weeks, sir. But in your day-to-day experience, what kind of maximum durability you can extend with your patient in your day-to-day experience, sir?
See, it depends. It depends on the type of case.
Right.
like if the patient is relapsing in every 8 to 12 weeks, he's relapsing. So it's
Yeah.
not a general rule like we can just
No,
immediately.
no, no. Then we have to shorten the.
So basically, what I do is after for Eylea injections, I generally prefer 6 weekly interval.
Right.
Even in the loading dose, I prefer 6 weeks because the patient is also much
Okay.
more convinced, and the treatment response I have generally seen that unless until it's very aggressive subretinal hemorrhage or something very aggressive disease, I generally prefer that 6 weekly interval is good for us cystoid macular edema cases or CNVM, early CNVM kind of picture. So I prefer 6 weekly interval. 4 to 6 weeks, because if you ask a patient to come after 4 weeks, they generally turn up by 5 weeks. It's not
Right.
like they will turn up on exact 4 week. So 6 weekly, and once the disease becomes stable, I initiate the interval to 10 weeks.
Okay.
10 weeks.
Yeah, it's a good.
I see how's the response, and generally 16 weeks I've been able to get very few patients who have been like, because what happens is that when once a patient turns up for 16, then they have a habit though of turning up at half a year interval,
Yeah, that's true.
half an year interval. They will
Yeah.
say that 6 monthly you will get once I checked.
Yeah.
So sometimes in this period also, like the first case which I was showing to you, this lady was initially having only dry ARMD, and there was very minimal SRF. So she was not very and she was maintaining this since past 2 years. So I used to tell her, you just come for every 3 monthly OCT scan.
Yeah.
Now, because she was maintaining good vision, so she started coming after 6 months.
Okay.
And suddenly she came in between
Okay.
with a large subretinal hemorrhage, and the vision dropped from 612 to directly 2/60.
Okay.
Now she's maintaining on 6/60, but this happens with this. So generally, these kind of patients, I prefer to call them every 3 months. And if I see if every 3 months like that, there is no fluid at all in OCT, then I can ask them, do you come after 4 or 5 months, something like that, if the patient is compliant. Because if you give them 16 weeks, they will say 6 months.
Yeah. They get it for granted. Yeah.
And once that happens, they will say, no, you only told. And then I am very particular about it that I give Amsler grid to all the patients, because Amsler grid also helps a lot.
Yeah.
So I give to all the patients, I tell them, you just keep every 2 weeks, you just go and the bright sunlight, see how's the letter, how's everything, how's the lines. If something is there, you should come. Yeah.
And sir, one question is from my side, that in many patients, sir, who are treated with for a other molecule like ranibizumab or other molecules are treated for a long time, might be at the early stage they are getting a good result, but after a few months or few years, that patient might be developed tachyphylaxis. So in that case, would you prefer to ship them to aflibercept, or you prefer to ship
See,
to a...
one thing is, if cystoid macular edema is there, like branch retinal. See, affordability is also a factor which you have to
Yeah.
see.
Yeah,
You have to
obviously, sir.
because see, you have to in the practical clinic, if you have to apply clinical practice, you have to see the finances.
Yeah, obviously, there's many things there,
Because if you just say that, okay, fine, if the ranibizumab biosimilar is not working.
No, it's working good.
No, that's telling that suppose you have given 3 or 4 doses, it's not working. Now, CNVM case, Ozurdex is not an option.
No.
Ozurdex is, so in that, I tell the patient, like, see, you have to go for this because this is not working. There's no point repeating the same injections because you know that the penetration is not that good for that molecule. So there is no point, like, for this finance sake, you're giving, it's better not to give injection rather than if it's not working at all. Just putting some injection, it's not working. But in macular edema, like branch retinal vein occlusion, something like that, and the patient is not affording. And so if not affording, then it's better to convince the patient, like what I do is convince for dexamethasone implant. Because once they will give at least 4 or 5 months stability, it will be there. But if suppose patient is glaucomatous, you cannot give steroid. Then I ask them to aflibercept. If the patient is affording, then that's not a problem only. So that's what I'm doing. I'm just balancing it out, like what is the socioeconomic status, how many injections he might need, what is the status of glaucoma. And in neovascular macular degeneration, though, there is no option only. You have to switch. So that is so grossly you have to keep everything in mind.
Right.
Otherwise, if you don't offer them all the treatments, if you just stick to it like, no, this is a treatment, I'll stick to it, Then
No,
the
no,
patient
yes,
will go to
many
patient
things
will
is
go
there.
to someone else. Patient will go to someone else.
Many things is there, so obviously, many things is there.
So this is the thing, but yeah, for CNVM, there is no question. Aflibercept is well proven. There's no doubt on it.
And hopefully, sir, for the end of this year, we are going to launch our HDs with
Ah,
and
no.
we have a study in that you can extend the durability up to 6 months. I
Ah,
think, yeah, in many patients, sir, there is a complaint like there's a main challenge is the compliance part. They don't like to take like so frequently injections. I think that part we can take care of with the HD.
yeah.
Hopefully, we are expecting that at the end
Why
of
you have taken so much time in bringing to India? Like it's already there in all the
yeah, all it is for last 3 years. It is in Europe. It is in USA.
Dubai also last year.
Dubai, yeah. You know, sir, we have the all approval from the US FDA, European Union. Still, our DCGI is you can understand, no, sir. There is something, so we could
No,
not be
but
able related to compliance. We could not be able to manage.
yeah.
That's the main thing. We're facing challenge. So that's thing. And recently, sir, Bayer took over the one company that is Perfuse. They have some research on their two two-phase studies there on DME. One molecule is on DR and another is on glaucoma. Both are implant. So Bayer is very aggressive on the opthal portfolio also. So fully within 3-4 years, we are going to launch in India that molecule also. So, okay. So thank you, sir. Thank you for your valuable time, and thanks all audience for your presence. And it's an immense pleasure to get you all with our platform. Thanks.
Thank you.
So now I'm requesting our tech team kindly log up this sign like link. So it will help our audience to log up the. Thank you, sir. Good day, sir.
Thank you very